andare al computer, magari ci stanno altri pezzi. No, 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 guarda.
People of all backgrounds and circumstances are made by God to be loved and cared for with dignity and compassion until the time of death. In a study published by the Institute of Medicine in 2014, however, it was revealed that the end-of-life experience in the United States is often characterized by futile care, physical and emotional distress, and spiritual suffering. It is evident that transformation is needed in the ways our society, not just our healthcare system, cares for seriously ill people, their caregivers, and their families. We know the solution. It is excellent medical care that is provided in ways that are highly personal, honest, tender, and loving. We call that comprehensive person and family-centered approach whole person care. Our Whole Person Care initiative is a formal, organized palliative care and faith community-based program being introduced in California. Through a partnership of the California Catholic bishops and the state's Catholic healthcare systems, the Whole Person Care initiative seeks to provide compassionate and loving support for terminally ill people, their families, and their caregivers. The initiative, which will also collaborate with others in the medical and faith communities, is designed to expand and enhance both spiritual and medical care to people living with life-threatening conditions, helping them make informed, ethical decisions consistent with their personal values and priorities as they approach the end of their earthly journey. By leveraging and expanding existing diocesan training systems, we will develop networks of volunteers in parishes who will provide skilled and compassionate pastoral support to frail and dying people and the families who love them. The initiative will strengthen ministries, dioceses, and parishes by making tools and resources available to support and implement whole person care. Additional pastoral applications include spiritual formation, extraordinary ministry for the sick and dying, bereavement ministries, and faith community nursing and social work programs. In the healthcare settings, the initiative will promote humanizing hospital spaces, enhanced training of palliative care specialists, establishing active collaborations between clinics and parishes with shared goals and metrics to improve care and quality of life for frail and dying people and their families. The initiative will build from evidence-based guidelines and national expert consensus recommendations to refine patient care processes. It will also provide a full-time service where patients can access palliative care as needed 24 hours per day. Through the initiative, a continuum of personalized, coordinated disease treatment and palliative care will become the standard in Catholic-affiliated hospitals in California. The initiative will comprise well-trained teams of physicians, nurses, and parish-based staff who recognize the transformative potential of this project. Together, we will demonstrate the feasibility of clinicians and faith-based community members to provide the best possible medical care, along with comprehensive spiritual, social, and emotional support for whole persons through the end of life. Our goals are twofold: to further education and training in parishes and Catholic healthcare to ensure that all who are physically dependent, seriously ill, frail, or dying feel wanted, worthy, and dignified, and to make the Whole Person Care Initiative's program and services available to Church and Catholic healthcare leaders for implementation elsewhere. Starting from where we are, Catholic healthcare and Catholic faith communities can work and learn together with the goal of providing reliably excellent, tender, and loving care for people through the end of life. Loved, wanted, worthy.
We are delighted to have the opportunity to chair this session. My name is Eduardo Brera, and I work at MD Anderson Cancer Center in Houston.
I'm Thomas Sitte from the German Palliative Stiftung and the Children's Palliative Care team in Germany as well.
In these meetings that are very intense and that have so many sessions, sometimes it's even hard to know if we are in the session we want to be in. This is the session on vegetarian cuisine. I hope you all are. And being right after lunch, we invite you to remain awake because this is important, this is huge. Policy and financial perspective is what might make this happen or not. We discuss how important this is from a clinical perspective, spiritual perspective, but if we can't make it happen from a financial and policy perspective, you will not have jobs and your patients will not get treated. And so we have a fantastic panel today to address these very, very important issues. Our first speaker is going to be Dr. Charles Normand. He's a professor of health policy at the Center for Health Policy and Management at Trinity College Dublin, Ireland. And this is a center that has been particularly focused on the financing, organization, and delivery of health care with a trajectory of great work in the area of long-term care and palliative care. And we're delighted to invite him to talk to us about achieving value for money in palliative and end-of-life care.
Okay, thank you very much. Thank you for coming after lunch and still being here. The organizers made one big mistake. They failed to point out that they were keeping the best till last. And this is going to be the most enjoyable session of the whole meeting. It's the most enjoyable one because, in contrast to Anne this morning, I'm actually delighted to be talking about economics and using the language of economics. It's what makes life good for me. And it's what I hope makes life good for everyone else as well. It is also a breach of human rights to ask any academic to speak for 20 minutes, and so I will only... All right, but it has to grow taller then. I'll be... praying and giving a presentation together is too complicated for me. So I'm afraid that some of the things I'll be talking about, I will only be giving a very brief flavor and trying to concentrate on the key points. And really the three key points I want to make, if you want to write this down, so if you do fall asleep, you'll have the key points available to you. The first is, these issues we're talking about are here, will always be here, and we need to embrace them and not be concerned by them. Second, it's difficult. In case you didn't get that one, it's very difficult because doing good studies on the value for money and the cost effectiveness of palliative care is very difficult, and the measurement issues, which I'll be talking about, are very key. And the third point is simply that we do in fact have quite a lot of evidence, and we need to try and draw on that evidence, and we need to identify where the evidence gaps are and try to build on those. If you don't notice that's what I say in the presentation, it was because you were not paying attention, not because I wasn't doing the right thing. So healthcare choices always have to be made. They are always with us. We always make choices on how we use resources. Sometimes we make choices without people seeing it, but we always make choices. Sometimes we make bad choices, but we always make choices. Running away from the need to make hard choices doesn't make them go away, it just makes it more likely they will be addressed in inadequate and insufficient ways. But in palliative care, the lack of good evidence on value for money and cost effectiveness has often been mistakenly seen as evidence of no value. So the lack of evidence of value is taken as evidence of no value. And I've often heard people say really intelligent things like, it doesn't really work. Not addressing the question of what it is or what we mean by work, but it's very commonly thought. And good evidence is easy to assemble where the objective is simple and the treatment is simple, so that you can easily measure something that is easy to identify with easy objectives. But in palliative care, the objectives are complex, the interventions are complex, and putting together good evidence is therefore very difficult. So, as I said, economic evaluation works very well where the interventions are simple and where the outcome is simple. So, for example, evaluating an eye surgery program, it's pretty simple. You know how many people have impaired vision. At the end of it, you know how many people have got good vision. You know they like it, they appreciate it, they can read more. It's a good thing. And you can work out how much it costs to do because you know how much the surgery costs or whatever the treatments are. It's pretty straightforward. And a whole body of experience has grown up around evaluating relatively simple interventions. And I would include things like hip replacements as fairly simple interventions. Can't walk without pain, can walk without pain. Not a terribly complicated change. It has some profound effects, but it's pretty simple. But with complex interventions, some of the metrics that are commonly used don't really work very well. Partly because it's actually difficult to measure what the intervention is sometimes. I'll be talking a bit more about this, but it's often a team effort, it's a collaboration, it's working through people, it's trying to change some of the underlying understanding of what we're trying to do, it's trying to change the planning of care. It's often doing things that are some distance away from simply saying, we do this treatment now. Most of the best metrics in current use work very well where we know simply what we're trying to do, what we're trying to achieve, and how we can link the intervention with the outcome that follows. In complex interventions, as I say, it's often difficult to define exactly what we're doing, but often the effects depend on what other people are doing around us as well. It's no good simply to say, I've got a really good support for decision-making if the change in decisions don't lead to a change in treatments. It has to be done through teamwork and that sort of thing. Also, people have an irritating habit of having opinions, wanting things, wanting to take part in the decision process, allowing their preferences to show, all these other inconveniences that take away that nice, simple, linear relationship between the problem and the solution. And people tend to have different views on what they're trying to achieve, what their goals of care will be. And often the outcomes are difficult to measure, and there are a number of reasons, and I'll touch on a few of them later on. This might seem like what we would call teaching your grandmother to suck eggs. That's to say, telling people things they already know. But palliative care is an approach as well as a service. It's a way of thinking as well as a way of doing. The goals may change and evolve as we go through the trajectory of needs and trajectory of care that we provide. We don't know on the first day what the pattern of needs and wants is going to look like, and we have to be able to adapt and change. It's inherently a team game. It's not a game that is well played by individuals. Another important point, and one I want to keep emphasizing, and I'm going to be a little dull on this subject because I'm going to come back to it several times. Often what people are looking for is availability as much as wanting actually to use a service. And this is something that we've found in our research to be hugely important to people. If I need it, will it be there? Not, I want it on Tuesday. And that need to be able to provide things in a timely way and a way that doesn't stress either the family or the individuals is a crucial part of a lot of what we're trying to do in palliative care. And also, outcomes can depend on a multitude of different things that we're trying to do. We're not simply saying we are putting in a pain control intervention. We're doing a pain control intervention in the context of a number of other things that are being done to try and help the outcomes and the quality of life. Another problem that makes comparison with other services difficult is often in palliative care we're looking at quite a short time horizon. People will often measure in ways that I'll be talking about in a minute, like quality adjusted life years. if you're dealing with an intervention that may have a duration of 6 weeks, you don't get very many life years out of 6 weeks. Even if it's better than perfect, you don't get very many life years out of 6 weeks. Now, just a few challenges on measurement, and I'll be running through these ridiculously quickly, but I just wanted them to be on the record so people could access the slides and the text. Defining the intervention can be difficult, and therefore what is it we're trying to measure can be difficult. I once knew a nurse who worked for the Macmillan Cancer Nursing Service who didn't actually see patients. She only saw people who saw patients. She worked through people, so if you counted how many patients she saw, the number was 0. But how much difference did she make? We hope the difference was huge. So availability can be more important than use. So how do you measure the availability of service for someone who doesn't use it, despite the fact it can be of great value to them? Interventions are often bespoke, and therefore it's not easy to define their overall content because they've been designed one by one for the different people who need them. Interventions occur over time and are linked to each other, so you don't know in advance what the interventions will be because they will change as a result of what's going on. My only question, though, is this in fact something that is very specific to palliative care, or is it indeed really the context for a high proportion of the healthcare we deliver? And one of the other sub-messages I'd like to send you off with today is that to a significant extent, the world is out of line with palliative care. It isn't that palliative care is out of line with the world, because people treat medical care and health care as if it doesn't have these characteristics, when in most cases I think it does. A nice statistic I always like is the fact that the great majority of people who see a family doctor have 2 or more chronic diseases at the time they see that doctor. It is very rare for someone to go and see the doctor because they have one problem. They almost always have multiple problems, and that means the context for that intervention is very different. A question of how wide we cast the scope when we're trying to assess costs in palliative care, because very often it is working with a broader group, and you have to look at all those knock-on effects. And some things that we do in palliative care are cost neutral or even cost saving, and I'll give some examples before the end, because some of the things we do actually reduce costs of care rather than increasing it. How do we cost things we don't use but are important to be there? How do we cost linked activities over periods of time? And how do we cost the consequences of effective palliative care? Now, we have a number of similar issues around assessing benefits. As I said, the widely used tools that are often used, like SF36 or EQ5D, if anyone doesn't know what these things are, they're in a happier state than I am, because you would often lose the will to live before getting to the end of some of this debate. But these are measurement tools that are trying to adjust our understanding of people's quality of life or their capacities, and you can use them to judge whether an intervention has changed or has not changed these things. But when you apply tools like this in palliative care, overwhelmingly you find it doesn't seem to show up as making much difference. So you often have the paradox that if you ask people how much they value something, they say they value it hugely. They then fill in the form and it shows that they didn't value it at all. Now, there are 2 possibilities there. One is that people are all stupid, and the other is that the measurement tools aren't working very well. I'll leave you to decide for yourselves which is the more likely explanation. But we have a lot of evidence that these kinds of tools only partially pick up differences that people consider to be important. And I'll come back briefly to this at the end. And there are 2 reasons, I think, for this. One is that the scope that these tools try to pick up tends to be too narrow, and the metrics they use to measure tend to be too insensitive. So there are good reasons, I think, why these tools don't tend to do well. Now, there is a body of research that is trying to develop better tools, and this is still in fairly early stages. I mention only 2 here. One is a set of tools that are called IceCap, based on the underlying ideas of Amartya Sen about capabilities that have now been developed to try and understand how palliative care type interventions do or do not make a difference. Another is the development of the widely used POS measures, which is trying to take measures that are commonly used in palliative care and convert them into ones that will show differences in health-related quality of life. The evidence around these suggests that they do pick up differences in a more sensitive way, and there's, I think, a lot of reasons to be quite optimistic that we're going to get better at measurement in this area. The problem remains, though, is how we ensure these measures are seen as comparable to measures that are used in other fields. Because unless you measure in a comparable way, it's difficult to make comparisons. And we have to be in the business of making comparisons because comparisons are the basis for decisions on resources. Another problem, though, is the problem of time scale. And again, if I had my full 55 minutes that I should be allowed here, I would give you a lot longer on time scales. But the issue around time scales is most measurement tools simply say an hour, a day, a week, a month is just a month. And it's a thing you can measure and you can add them together. But if you imagine yourself going on holiday, if I said to you, how was your holiday? You said it was really great because I had 15 days instead of 14 days, and that extra day made all the difference. It made it a holiday that was worth 8.5% more. Does any of you say that? Or do you say, I had a great holiday. It had a great time in the middle, and I came home after the family all got together and they were nice to me. That was, so the way you think about something like a holiday doesn't say, it was the addition of day 0, day 1, day 2, day 3, day 4, day 5. It was, how did I feel about the whole experience? And yet people will go around measuring outcomes of healthcare interventions as if you can add up the days. My argument is, in some senses, you can't add up the days. If you try and add up the days, you get nonsense because that's not the way we conceptualize an experience. It's not irrelevant, but it's not the simple way in which we do that. So time, I think, cannot simply be added. And as I said, I can be very long-winded on that subject, but they're not allowing me to be. An alternative approach, then, is to try and measure what people value. Can you measure more directly? How do people feel about different packages of care, different experiences of care? What are the things that really made a difference to them? How would they make better choices? And we've done quite a lot of work using a technique called discrete choice experiments to try and understand what people really like. What are the things that really seem to matter to them? What are the characteristics of care that seem to make a difference? And you can ultimately begin to say, does that give us a basis for looking at value for money? Is it good value because it does things that people want and it does things they want well? And a number of interesting things have come out of this work, not least the style of delivery is often at least as important as the content. People didn't simply say, it was very good because they did the following assessments. They gave me the following treatments. It's saying, when I wanted someone, they were available. And when they were available, they were trying to help me with my problem. And I wasn't left hanging, waiting for people to be available on Monday. You know, it's a great coincidence that people, when they're sick, choose to be sick only Monday to Friday, 9 to 5. At any other times, they're obviously well. And yet, we organize our lives around the possibility that people have this nice pattern of ill health that only occurs conveniently on weekdays and not too late in the evening. I know that a lot of us do organize our care in a more benign way, but if you look at the overall provision of healthcare, it's got that tendency to shut down. People are very resistant to be left without support, and one of the things that comes through very strongly is the preference people have for well-coordinated access to competent, skilled individuals at the time when they may need that help. And I can come back to that if I've got time at the end. So I'll give a few examples of what people have shown us really matters in the style and the things that make a big difference. I say, first of all, process as well as content, the style of delivery as well as the content of delivery, availability, avoiding hassle to informal caregivers and families, ensuring that people have access to support so that you're not putting the overall burden too heavily onto families and informal caregivers. And minimizing this burden on family is valued particularly because if the family isn't burdened, it's able to do what it can only it can do. I'll just come back on this for a moment because I think it's a very important finding, and that is, in general, families seem to have something approximating a fixed time budget available to provide informal care. If formal care takes a lot of the burden off them, they do the other things that they want to do, which are more spiritual, more supportive, more to help the whole person. If formal care is not available, they tend to do more of the routine physical management of someone's needs. And we've traced this in some detail, what people actually do as a result of different levels of formal care being available. That means that if you hassle the family, you take away the thing the family does best and nobody else can do best. So I think there's great importance in understanding the importance of supporting those who support as well as supporting the patients themselves. Prepayment, that's to say not delivering someone a bill on the day when they take the service, is hugely valued. That's to say getting access without feeling you're negotiating what you're paying for and who's paying for it and how it's being paid for. And that's clearly valued to a huge extent. And participating in making choices is also valued to a great extent. Now, I'm just going to finish by giving a few examples of things we know from studies that have been done that suggest we can actually use some of the existing evidence quite well. First of all, from a study looking at palliative care specialists put into emergency departments. And the key thing that came out of that was you can reduce the number of people admitted to hospital, you can reduce their length of stay, and you can get better experience of quality of life if you do that. We've got similar issues in studies we've done in other countries, which have shown expert decision-making can improve the experiences and improve outcomes and can reduce the amount of treatment people have, and they show better experiences at the end of that. I can, I'm just going to skip ahead because it's more important to get to this. Sorry, my slides are not what they're meant to be. I will just have to finish without looking at them. The other thing I was wanting to emphasize is that a number of studies we've done in the US have shown that if you put a palliative care team into a context of someone admitted to hospital with life-limiting disease, it unambiguously shows that they have a better experience, better quality of life, they have fewer treatments, and they have a shorter time in hospital. It also, in some studies, not ones I've been directly involved in, has shown that people live longer as well. In these cases, we're saying palliative care is free. It's more than free because it releases resources. And if something does a better job at a lower cost, it's actually quite difficult to construct the argument why you shouldn't do it, if you can get better for less. And I think we've got to look for, first of all, for where we can get better for less, and then we say if it is better for more, it's probably got to then show that it's better value because it gives you more for more. I'm sorry, there seems to be a problem with the slides as they've come out, so I have been a little incoherent at the end, but I just want to repeat my 3 points in case you didn't notice them at the beginning or have forgotten. First of all, these issues are with us forever. They're not going to go away. We must embrace them rather than run away from them. Second, it's difficult to do some of these measurements, and some of these evaluations are hard to do. And thirdly, we do have some evidence, and we should be trying to move to use that evidence to argue the case for resources, particularly where they are unambiguously good value, as they are, at least in hospital care, in trying to improve people's experience of hospital care by providing expert support for decision-making. Thank you very much.
Thank you, Charles, and I'm very sorry to cut your time, but we have to hurry up. But anyway, I want to take 1 minute for a remark and to ask a big favor. Yesterday, Catherine, maybe some can remind, had a quotation at the last slide that only a small group of thoughtful, committed citizens can change the world. We are such a small group. And last year I've been to the G20. There was a G20 summit in Berlin, and there was a B20 health summit in Germany, in Berlin. I've been there. And there was lots about access to healthcare, access to prevention, access to treatment. And there was not a single word about palliative care and hospice. Next year, it's in Buenos Aires. Maybe some have contact to a health institution in Buenos Aires, to ministry. Ask them to implement some words, some phrases about palliative care. Maybe we can change the world with it. And thank you, Nikolai Pfeffer, for the introduction with the music. He made a CD with Brahms, Johannes Brahms' last masterpieces. Sometimes the best thing in life are very close to the end. And we had this CD for the chairs, and for the speakers, if they want to, we can hand it out afterwards. But now I want to introduce Thomas Vaikatu Parambil. Thank you. He's from Kerala, South Indian, and there he is the director of the Lessi Health Institutions for advocacy, for education, and for healthcare as well. And I found a very interesting sentence on the website of Lessi Institution. Our mission serving society by promoting health and making world-class treatment accessible to each and every person. I think palliative care is world-class treatment. The floor is yours, Thomas.
Yeah, of course. Anche I bambini, quelli più vivaci, dormono a quest'ora. Anche senza ninna nanna, questa è la verità. Perciò noi cominciamo con una preghiera. This is a hymn in Sanskrit. You know the Vedic prayers. It is just like this. Asato ma sadgamaya, tamaso ma jyotirgamaya, mrityo ma amridam gamaya. Om Shanti, Shanti, Shanti. This hymn was written 350 years before Christ from Brihadaranyaka Upanishad. The prayer which we are saying, O Lord, guide us from the unreal to the real. O Lord, guide us from darkness to light. O Lord, guide us from death to life. Peace, peace, peace. Shanti means peace. This morning we heard about the spirituality and the spiritual involvement in the palliative care. I think each religion is bringing this reality. If Lord can come here and respond to us, he will say, what he will say? Now you are here to help my people to guide from death towards the real life. My dear friends, in these days, these 2 days, we heard these things. The spirituality, the palliative care is giving literally strength to our society to learn the value of each human being. Our Pope Francis says, palliative recognizes something equally important, recognizing the value of the person. Literally, it is our duty now to recognize the value of human being. Our Thomas Sitte introduced me by saying I am representing Lessi Hospital. I think in these days, we heard a lot about the policy, WHO insisting to introducing something, and we heard a lot. So we have these topics here. I want to avoid some of this because yesterday and today morning we heard a lot about WHO policies and how we have to start with, how we have to create all these policies, etc., etc. I'm representing CHAI. You have heard from Father Joby yesterday about CHAI, the group of hospitals and healthcare providers in India. We are giving best care. That was Thomas Hitter said. It is our duty to give best, because our founder says always this thing: the poor deserves the best. That is the reality. The poor deserves always the best thing. So, any national policy, palliative care policy should align with WHO 6 core components, building blocks of healthcare systems. Let us go forward. Let us see these policies, a government policy, to ensure the integration of palliative care services into the structure and financing of the national healthcare system, an educational policy to provide support for the training of healthcare professionals, volunteers, and the public, a drug policy to ensure the availability of essential drugs for the management of pain and other symptoms and psychological distress, in particular opioid analgesics for pain relief. All three of these measures are necessary, along with committed leadership, to achieve an effective palliative care program. Yesterday and today, this morning, I have from our leaders, from these masters, the capacity what they have, the teaching which guide them towards the reality of real palliative care, and to make good policy to ensure the real palliative care to each and every person of this world. Let us look at the church. We have just seen that video. The Canadian and the American Catholic Church, they are introducing all those things. I think the Catholics are blessed in a sense. Why? Each first Friday, the priest or one minister will bring Holy Communion to the patient who can't move from the house or who can't move from the bed itself. So they have a kind of attention. I think the church, the NGOs, and all those persons who have the good soul will gather together to do the best thing. Roman Catholic Church is the largest non-government provider of healthcare services in the world, with largest health workforce. For example, in India, we have 3 associations. One is CHAI, Catholic Health Association of India. Second one is Caritas India. The third one is the Health Department of CBCI, Catholic Bishops' Conference of India. These 3 structures are creating the best care ever we have seen. Let us, long before the concept of palliative care into vogue, the Catholic institutions are all over the world were taking care of geriatric, sick, and terminally ill patients without discrimination of the basis of place, race, caste, and creed. Their services was devoid of publicity. In Indian health scenario, more than 70% of healthcare services provided by private healthcare centers and hospitals. Palliative care in Lisi Hospital. Our hospital, a charitable institution of the Archdiocese of Ernakulam Angamali, located in Kerala state. Kerala, you know very well, the southern part of India. Holding the motto, care with love, close to our hearts, we accomplished our mission of providing high-quality treatment of global standard for all and at affordable cost for the less privileged, irrespective of caste and creed. Even in this era where healthcare services are being elevated to a concept of healthcare industry with profit motives, we uphold the following. We do not have profit motive. We do not have a profit-making marketing strategies such as products or service promotions and advertisement. The patients are our billboards. Lisi Hospital is the pioneer in healthcare services, offering refuge of people who cannot afford to go to the expensive corporate hospitals for the last 62 years. The team of dedicated doctors and staff run the pain and palliative clinic in our hospital. I'm so proud to recognize that our master of palliative care, Palliative India, Dr. Rajagopal, he is the person who instructs our doctors to guide this palliative care in our hospital. Now there are 7 doctors who are guiding this palliative care center. And the relationship between interdisciplinary departments, for example, oncological department guided by the son of Rosakuti Madam, the HOD of the palliative care, they're collaborating in a special way to give the best care to our patients. It is a model to our CHAI group of hospitals, and most of the nun sisters and other hospitals are coming to our institute to learn about the system of the palliative care. We are giving free OP and IP home care for all those poor persons, counseling service and spiritual support to the patients as well as to the family, preparing for all peaceful end of life. Patient-friendly environment. A group of well-trained volunteers provide service to the patients from the vicinity of the hospital area and give regular feedback. Let us go forward. Our welfare programs. I have mentioned about Caritas India. Caritas India is a leading non-governmental system in GEO. Now, Caritas India is keen about Asha Kiranam project. This Asha Kiranam project is a preventive project for the cancer. They are making around 26,000 volunteers who are helping the entire society to learn about the cancer, awareness about palliative care, and awareness about the medicine. And they are guiding these people. Volunteers means they are the persons who are retired from their services. They are doing some other work, college guys, youth from different sections. They are not Christians. Most of them are not Christians. But they are collaborating with us to guide these people to make a better care and best lifestyle. Prevention, awareness, education, early detection screening, proper and adequate treatment, good food and palliation. Now, the concerns. When we are creating these policies, when we are saying about the policies, we have to create the policies to all, not for somebody or some group. Yesterday we heard about the accessibility. We have that accessibility to all. Even in India, I think now the 3% of the patients who need palliative care get palliative care properly after creating all these systems. Yesterday, Father Joby mentioned, we have around 860 palliative care system in Kerala only. But apart from Kerala, it is really a situation we can't imagine. That is a real scenario of Indian palliative care. The concern, lack of facility, lack of awareness, misconceptions and myths, lack of health education, chemicalized food intakes, lifestyles and practices, lack of fund in healthcare policy, lack of support system, example, the proper palliative care system. The program tree. Here, we, the CHAI, is collaborating with Palliative India. We are collaborating with Caritas India to promote healthcare, especially to train all of these persons who can give better care. Now we are saying about the policy and financial aspects. Why I am here? Our question is this: what I can do, not what government can give, what the policies will counsel to do. What I can do, that is a question we are raising. And we are doing the better service. Caritas India and Lisi Hospital, social mobilization prevention, technical support for education, training for palliative provides, 20,000 community doctors in 5 years. That was the hope of the CBCI. The Bishops' Conference of India is suggesting this to Caritas India, to CHAI, and to the Office of the Health Associations in India. So we are collaborating together to achieve this aim. our educational policy. Now the educational policy yesterday, we have mentioned our central government honored Dr. Rajagopal with Padma Shri. I think if our government will hear our Dr. Rajagopal and our system to introduce a new educational policy, if they are ready to introduce the palliative care education in nursing and for MBBS, for doctors, it will be a great honor to these persons, to the persons who are giving the life for palliative care, giving the life for the life of others. But unfortunately, when we are creating this kind of policy, we haven't any position there. So now we are thinking about our own policy to educate our young people to give best education regarding the palliative care. The rest of the thing, create the awareness to their doctors and to nursing staff, etc., etc. So for the last 56 years, Lisi Medical and Education Institutions have modeled a considerably large number of nursing and paramedical professionals who are now grown to a state of catering medical services in countries all around the world, spreading the core values of Lisi Hospital. Lisi Pharmaceutical, that is the best thing which we have. For the last 48 years, we have one pharmaceutical company. We are producing narcotic medicine. And we are giving the narcotic medicine with the lowest rate. For example, the government fixed the morphine tablet, the rate is 4 rupees, which was the maximum price is 4 rupees. In our pharmaceutical, we are giving with 1 rupee. 1 rupee 10 paise. It means with €1, we will get 73 morphine tablets. That is the count we can realize. What we are saying about all these things? It is our duty when we are saying about the accessibility to the drug. It is my duty to give to our poor patients the medicine. The government, in this sense, they are collaborating with us. They give the license to keep 100 kilo of opium to produce the narcotic medicine. My dear friends, it's a great chance to the Catholic Church to provide this service to the society. When we are saying about the financial perspective, we have the funding system. We are doing all the care which offered by the government. It means the lowest rate the government is suggesting to do, for example, dialysis 660 rupees. We are doing that, and government is paying that much money only. For example, the corporate hospital and private hospital, they'll get 300 rupees, 3,000 rupees. For the transplant of kidney transplantation, we'll get 1 lakh rupees. The private sector, they will get at least 4 lakhs or more than that. What we are doing is, in our Lisi hospital, we are doing this kind of service to serve the poor with the government. We have this particular kind of policy to collaborate with the entire system to be a model in our healthcare system. The future palliative care, the future of the palliative care witnessed a patient care explosion, palliative care explosion, of course, because we have a lot of patients. When we are saying about cancer, when we are saying about other diseases, we need palliative care. We have to create the increasing population of older people, rising incidence of cancer as well as cancer-afflicted living longer, and above all, the recognition of supportive and symptomatic care requirement explains this explosion of needs. The country. When we are saying about the policy, we have to assure one thing. I don't know, yesterday my friend from Africa says that if WHO create one policy, we are satisfied because we can bring it in front of the government. We are in Kerala. The last session of our assembly passed the Clinical Establishment Act. Only in the last session of the assembly, they passed the Clinical Establishment Act. What I'm saying is these policies and all these norms and regulations which world has, it is a desire, it is a future. We have to achieve these things as soon as possible. When we are saying about the percentage of the people who can access this care, it is only 1% or 2%. We have to think about this 98%. So, my dear friends, it is our turn to do something to get best care, to give the possibility to access to the medicine, to the care, etc., etc. Now, what can the church and NGOs do? We have heard a lot about this. We are here. I have to congratulate our Monsignor Vincenzo Paglia and the team for this best gathering where they are creating a core team. The world is here, no doubt at all. The world is here to hear. The world is here to bring the message, to pass to our leaders, to our government sectors, to our NGOs, to our youth, etc., etc. How can we reduce the cost of palliative care? We have heard from our economist how we can reduce the cost. In India, we have a model that is called ASHA, Accredited Social Health Activist. That's from the part of the government. They are keeping in each village a social worker who will take care of these poorest patients, who will take care of all these situations. But it is not well practiced in all sense. But it's a very good community health project and program. A 24-hour helpline we are introducing among our hospital. We have around 300 systems in Kerala only. We are creating one 24-hour helpline. So, if one patient is in need, has the problem, he can call and the doctor will go to that particular house and give help. The volunteers are giving the help to bring this particular doctor to that house. That is the helping system which we have. More people from general population must join as volunteers. When we are saying about the volunteers, I have in our hospital more than 780 volunteers who are giving their time, their money. That's the most interesting thing. Most of them received the care from our hospital. Most of them had palliative care patients in their house. After receiving this care, they are taking care of other patients. That is the best thing which I have experienced in the system. If our volunteers have time, have money, it is not money because they have money in their pocket. What they are doing? They are doing some other works. For example, college students are going to help the hotels in Sunday. On Sunday, they are going to hotels and they are bringing that money. We have CSR projects from the biggest group of corporate sectors. They are giving money to the palliative care system. So, my dear friends, if we have the capacity to announce, we are here. If we are transparent, our people will come. They need leaders. They need good persons who are giving the possibility to do something for others. That's the most important thing. I am concluding. Here there are some points. We are already facing barriers of need supply deficit. Yesterday our friend from Ireland was speaking about the necessity of nurses. I think from Kerala, now we are running around 120 nursing colleges. We are sending a lot of nurses all around the world. In Ireland last year, I think 1,500 they are recruited directly from Kochi only, the nurses. We are sending these persons. So the major part of the nurses or clinical service person are going from our place. Now what we are doing, we are creating volunteers with the help of Caritas. Who are these volunteers? These persons are working, 1 minute, our persons are working in our diocesan setups, SHG members, self-help group members. They have their own work, they have their own market, they have their own earning, but they have enough time to spend. They are creating a network system. This network system is functioning very well. All of the dioceses We have 30 dioceses. We have more than 75,000 volunteers from different dioceses. So, my dear friends, what we are doing now, we are creating this kind of service. We are creating this kind of policy. We are making money. We are not poor. We have enough money. So, palliative care everywhere and by everyone. This is our theme of this contest. I think to do this, we are going forward. We are synchronizing with all agency. We are doing all the best practices to give health care, palliative care to everyone. Thank you.
Thank you very much. Our next speaker is Dr. Howard Koh. Dr. Koh is the Harvey Feinberg Professor of the Practice of Public Health Leadership at Harvard School of Public Health and at the Harvard Kennedy School of Government. Dr. Koh was appointed the Under-Secretary of Health at the U.S. Department of Health and Human Services between 2009 and 2014. So he has a very wide experience in clinical, academic, and government roles. We share with Dr. Koh, and we learned this morning that we share an extraordinary mentor in Dr. Wong Ki Hong, who recently retired as the chair of the Division of Cancer Medicine at MD Anderson Cancer Center. So I think we have common sources for our knowledge, and we look forward to his presentation that will be in the area of policy dimensions of spiritual care in the United States.
Thank you very much, Mr. Chairman, and it's indeed a great honor to speak before this inspired global audience on these truly sacred topics in this holy setting. It's my great pleasure to speak on the topic of policy considerations for spiritual care in the United States, and I'll be giving this presentation from multiple perspectives. As a physician who has trained in multiple fields, including cancer, as a clinician who has cared for patients for over 30 years, as a professor of public health at Harvard, and perhaps most importantly of all, as one who has held major policy positions in health in the United States. First as Commissioner of Public Health in Massachusetts from 1997 to 2003, and then, as the chairman has noted, most recently as Assistant Secretary for Health in the U.S. Department of Health and Human Services under President Obama. And through my travels in these various roles, issues of meaning and purpose and spirituality have guided me from the beginning, both professionally and personally. So, for example, when I think of issues of meaning, purpose, and spirituality, I often think of my friend and mentor, the late Reverend William Sloan Coffin, who was the chaplain at Yale University when I was a student there. Reverend Coffin used to remind us that we cannot view a patient as an uninteresting appendage to an interesting disease. He also said that the primary religious and spiritual emotion is gratitude. So in that spirit, I want to say that I'm very grateful to all of you. I'm grateful to the organizing committee, with special thanks to my dear friend, Dr. Christina Puhalski, whose name will be mentioned multiple times in this presentation. I'm very grateful to my wife, Dr. Claudia Arag, and my son, Stephen Koh, who have joined me in this very special trip to Rome. So for this presentation, I'll be sharing some insights on health and spirituality and spiritual care, making some observations about how those themes apply to hospice and palliative care in the United States from a policy point of view, and then make some concluding observations about how this can extend in broader contexts in the health system of the United States, first in Veterans Affairs, the VA, and then ultimately beyond. So it was in 350 BC that Aristotle first said, the soul is the full actualization of a person, incorporating the body, the purpose, and ultimately the sum of total operations of being human. And then I was so glad that my colleague from the WHO reminded us of this truly inspiring definition of health that I repeat in just about every speech, that health is a state of complete physical, mental, and social well-being, and not merely the absence of disease or infirmity. I love that definition. I love it so much I'm going to say it again. Health is a state of complete physical, mental, and social well-being, and not merely the absence of disease or infirmity. This means that if we truly care about health, we need to pay attention not just to the health of the body, physical health, but also of the mind, mental health, and also health of the soul, social and spiritual well-being. And then, of course, the other very inspiring quote from the WHO in 1946, the enjoyment of the highest attainable standard of health is one of the fundamental rights of every human being. I love that phrase, the highest attainable standard of health. That means that our good health is a gift, and it's precious, and it's fragile, and it needs to be cherished, and it needs to be protected, and that's what public health is all about. In the United States, our country of 330 million or so, we are having vigorous conversations about the future of health for multiple reasons. First, we have the most expensive healthcare system in the world without the health outcomes to match. Our health system is highly fragmented. It has a traditional payment model called fee-for-service. That means if a doctor or a hospital provides a service, they get paid. If they do more services, they get paid more, regardless of whether it ultimately helps the patient or not, regardless of whether it's efficient or equitable or is something that the patient even wants or not. It's specialty-driven. Our insurance coverage is a patchwork. It's a mix of private employers that covers about 160 million people in our country, a Medicare, an insurance program for those 65 and older and disabled. That's about 55 million people in our country, or Medicaid, which covers over 70 million. That's insurance coverage for low-income or disabled people. Sometimes there's confusion about whether a person should be covered by Medicare or Medicaid and is eligible for both, what we call dual eligibles. And you put this all together, it's very fragmented. There's little coordination, high costs, and tremendous frustration. So it was a great source of great privilege for me to be Assistant Secretary at the Department of Health and Human Services when in March 2010, President Obama signed the Patient Protection and Affordable Care Act into law. We can say a lot about what the Affordable Care Act has accomplished and not accomplished in the 8 years since. We know that 20 million more Americans have achieved health insurance coverage than before this act was signed. There's tremendous controversy about where we should go with this act and how we should cover more people at lower cost and at high quality. But regardless of who you are in these controversies, there is universal consensus that the goals for the future for our country is more patient and person-centered care, care that emphasizes quality in the system and quality for the patient, that's coordinated and team-based. Everyone is looking to move beyond the traditional fee-for-service payment model into so-called alternative payment models that stress value over volume. And through all of this, we want to honor patient preference in the medical decision-making process, which sometimes is honored currently, but oftentimes is not. So in the midst of this, we can talk about issues of spirituality and spiritual care. You heard this morning from Dr. Puhalski that there was a very important consensus conference defining spirituality as a dynamic and intrinsic aspect of humanity through which persons seek ultimate meaning, purpose, and transcendence. We can talk about dimensions of spiritual distress, needs, and struggles. Many speakers here have talked about some of those dimensions. Here's a checklist offered by Busing that said that some of those dimensions involve social, emotional, existential, and even religious dimensions. When I returned to Harvard as a professor some 3 years ago, after being in Washington, I had the great privilege of joining some colleagues in a relatively new Harvard initiative on health, religion, and spirituality. The three leaders of this initiative that I want to mention today. The first is Dr. Michael Balboni, who's pictured here. He just recently co-authored this book called Spirituality and Religion Within the Culture of Medicine. And then the other two leaders of this initiative, Drs. Tyler Vanderweel and Drs. Tracy Balboni and I, had the tremendous honor of writing this little viewpoint in the Journal of the American Medical Association, JAMA, that was published last summer, entitled Health and Spirituality. You see this entitled in the lower right. And in this, we review some of the challenges and opportunities regarding spiritual health in the U.S. We have a highly diverse country with respect to race and ethnicity. Having said that, some 77% indicate a religious affiliation, about 46% Protestant, about 20% Catholic. Many patients, sometimes almost all patients, regardless, depending on the study you read, call spirituality important in their lives. About a third attend religious services weekly, but most receive minimal or no spiritual support from medical teams. This lack of spiritual care is a prominent source of patient dissatisfaction in hospitals. Spiritual distress is common, and these issues don't affect just patients, they affect providers too. We know that chaplains provide very important spiritual care services, but they cannot bill separately or be reimbursed. Medical providers say they don't have the time training to provide such spiritual care. And then right now in the medical literature in the United States, there's tremendous attention to physician burnout. And we suspect that spiritual health issues are driving a lot of this, with about half of US physicians reporting exhaustion and burnout and questioning the meaning and purpose of a lot of their daily work. So these are broad issues that affect patients and healthcare providers alike. So let's start from a very broad epidemiologic viewpoint, because if you look at these first two studies referenced here, it just shows the potential of addressing these issues and improving ultimate health outcomes. The first study has to do with religious service attendance, and this is in the Harvard Nurses Health Study led by my colleague Dr. Tyler Vanderweel, who is noted here, a study of some 75,000 participants. And Dr. Vanderweel and colleague noted that people, nurses in this particular case, who reported regular religious service attendance had up to a third reduction in all-cause mortality. And other studies have shown reductions in risk in depression and in suicide. So we could have a long debate about whether that's association or causation, but this link is very strong. Lots of discussion about what's causing this at least strong association or correlation between regular service attendance and improved health outcomes. Is it because religious service attendance involves community? Is it because it involves direct provision of care from spiritual leaders? Is it because there are healthy norms being practiced, like tobacco-free environments? There's much more research that needs to be done. The second study is a meta-analysis of 10 prospective studies of about 136,000 participants, showing that possessing a higher sense of purpose in life is associated with a reduced risk for all-cause mortality and cardiovascular events. So this is a very striking association as well. We know that when we integrate spiritual care into healthcare, it enhances satisfaction of patients at hospitals. So now there's some early work to see if there are specific interventions that can try to explain some of these broad correlations that I note here. There was a review in PLOS One in 2017, a systematic review of religious and spiritual interventions that showed small benefits, but of course suggested that more research was needed. So we're looking to try to identify specific interventions, given all the caveats that my colleagues have mentioned about how hard that is to do. So right now we're trying to build the evidence base for spiritual care, asking some basic questions. What is it? How do we deliver it? Who will deliver it? For whom and when? Some of those questions are addressed by Dr. Harold Koenig in this book that you see on the right, Spirituality in Patient Care. And there have been expert groups who have convened and offered some models for spiritual screening and spiritual history taking, which can be very brief and potentially offered by any clinical provider, backed up by a more in-depth spiritual assessment that could be extensive and could be conducted by board-certified spiritual care professionals. So in this model, and Dr. Puhalski referred to it this morning, we could have, for example, physicians and chaplains working together to implement various aspects of this inquiry. And this summary of the state of the science was reported in this publication below, led by my colleague, Dr. Tracy Balboni, and I know that Chaplain George Hanso is in the audience, is also a co-author on this paper. So also discussions about exactly how to begin to assess this information from patients to do spiritual screening and history taking. How do we even broach the topic and allow this conversation to go forward? Here are some suggestions. So on the top left is a publication that involves colleagues that include Dr. Susan Black from Harvard, a colleague of mine. Communication regarding serious illness should address some 8 domains with questions like, what are your biggest fears and worries about the future with your health? On the right, a little summary of the FICA tool that Dr. Puhalski has led globally, asking about faith and belief, importance, community, and addressing this in care with a sample question such as, how would you like me, your provider, to address your spirituality in your health care? And then on the lower left, another publication referring to the impact potentially of asking one simple question to probe spiritual concerns at the end of life: are you at peace? So we can debate about which one of these to offer when, but at least we use these tools to begin the conversation and elicit key information about spiritual health and spiritual distress. So how do some of these themes apply to hospice, palliative care, and then more broadly in the U.S. health system? Let's start with hospice and palliative care. One slide on hospice. You've heard a lot about hospice in this conference already, and the pioneering role of Dame Cicely Saunders. In the United States, the first hospice was opened up in Connecticut in 1974 by Dean Florence Wald of Yale, and she is pictured here. But I mentioned these themes have great personal connection with me, and on the right I also want to honor Reverend Edward Dobohall, who was a family friend of ours when we were growing up in Connecticut, and he was the chaplain at Yale New Haven Hospital. And I remember fondly as a young boy hearing him speak about how inspired and honored he was to help found the first hospice in Connecticut along with Dean Wald and others. So I picture Reverend Dobohall and honor his legacy here. We can now say there are about 4,000 hospices in the United States. In terms of policy, in 1982, a Medicare hospice benefit was introduced. And in 1983, an accreditation process by the Joint Commission, which accredits healthcare institutions in the United States, was begun. And below you can see a little more details about the Medicare hospice benefit. As noted by our rabbi colleague this morning, this is specifically restricted to people with less than 6 months to live. It covers the cost of non-curative care for terminal illnesses. This care is usually provided at home. The good news is that hospice has been shown to lower hospitalization rates, ICU admissions, invasive procedures, and total costs. There's a reference on the lower right by David Cutler and others from Harvard about these outcomes. But this benefit covers all services to people at the end of life and does not necessarily single out spiritual care or necessarily specifically reimburse spiritual care. So here is a venue where perhaps more can be done. And then palliative care in the United States, we've heard already how the WHO statement has been very important in advancing palliative care in our country. I did want to refer to this 2015 landmark report by the Institute of Medicine, the IOM, now called the National Academy of Medicine, called Dying in America. And this IOM report states that of the 8 core components of end-of-life care, which you see below, one of them, or rather 2 of them, refer to frequent assessment of patients' physical, emotional, social, and spiritual well-being and attention to patients' spiritual and religious needs. So this report is absolutely the go-to document in the United States in terms of the current status and the future of palliative care in our country, and spiritual distress and spiritual needs is explicitly mentioned there, but perhaps not enough. One positive outcome of this report was that Medicare, in 2016, as you can see in the middle of the slide, agreed to start paying physicians to have advanced care planning conversations and discussions. So billing codes were set up for advanced care planning. It reimburses perhaps not enough money for physicians who are committed to starting this conversation and coordinating such care. A recent study just came out saying that only 1 in 3 Americans completes such advanced directives for end-of-life care right now in our country, so that's way too low. But at least there's been some policy advancement about reimbursing physicians to start this process and realize the potential of the Patient Self-Determination Act, which was passed in 1990. Back to this Dying in America report by the IOM in 2015, they concluded with 5 key recommendations for palliative care. So I list them here. Insurance coverage of comprehensive care for individuals nearing end of life, develop quality standards for clinical patient communication and advanced care planning, create professional education certification and/or licensure, and that's not just physicians and nurses, but also chaplains and social workers and others, improve payment systems and policies, and expand public engagement and education. I have bolded where they specifically mentioned spiritual needs and spiritual care, and it's specifically mentioned, explicitly mentioned only in the first recommendation, so you see that on the top. It's implied throughout the others, and perhaps we should be doing more about that in the future. Let's move on to the Veterans Administration, which is the largest integrated health system in the United States, with 170 medical centers and over 1,000 outpatient sites taking care of some 9 million enrolled military veterans. This is a system that has explicit policy and procedures ensuring availability of spiritual and pastoral care for all patients. On the bottom, you can see a great rise in the delivery of such care within the VA system. They benefit from the implementation of a national bereaved family survey. You can see some results here. The 90% of veterans' families want spiritual support, and 70% or so always or usually receive that kind of spiritual support, so that is very impressive. So we have some data here to show that provision of such support by chaplains and others is starting to address the need. This is information from Dr. Joe Francis of the VA. And the VA is starting to do more in this area as they address key issues like suicide. For example, in some years, such as 2012 and 2013, suicide deaths are more common than combat-related deaths among military personnel, and there have been attention for spiritual care of veterans to, of course, make this tragic outcome less common. And then some last minute on how this could be advanced in the broader health system. As I mentioned at the outset, addressing spirituality as part of national attention to physician burnout could be another way of getting more broad attention to this topic. This first article is one that just came out in the New England Journal of Medicine last month, Beyond Burnout, Redesigning Care to Restore Meaning and Sanity for Physicians. And I put this quote on top from one physician: "At the highest level, we are disconnected from our purpose and have lost touch with the things that give joy and meaning to our work," unquote. It'd be fascinating to have U.S. physicians to talk about spirituality more explicitly and see how that relates to the burnout crisis. So more discussion on that. In the last slide or two, I mentioned that in February, just a couple of weeks ago, the President signed the Bipartisan Budget Act into the law, which now enables certain provisions of the so-called Chronic Care Act of 2017 to move forward. This is an alternative payment model to provide more Medicare benefit coverage for care delivered at home. This could include interdisciplinary care from teams that may include a chaplain, minister, or other clergy. Some groups in our country would like that word "may" to be changed to "shall," but the good news here is that there's some respect and attention to the importance of interdisciplinary care teams in a context like this. And then, as I mentioned, we have tremendous discussion about alternative care models, alternative payment models for the future. Many in the U.S. are familiar with the so-called accountable care organizations, groups of doctors and hospitals and other providers providing coordinated high-quality care to Medicare patients. There's also a model called accountable health communities that try to share responsibilities and coordinate responsibility throughout entire communities and measure health outcomes. This is where I believe faith-based organizations can be tremendous leaders, joining with medical groups. When I was in the Obama administration, it was a great honor for me to work with the U.S. Federal Offices of Faith-Based Partnerships, which was established in 2001 by President George W. Bush and then extended through the Obama administration. So this is, again, an explicit way of joining religious and spiritual leaders with health leaders to promote cooperation and collaboration about health issues. So I look to this office, hopefully, to continue that conversation and move that collaboration. And so as I end, what is the vision and what could be next steps for the future of spiritual care? When we ask what, it should be patient-centered communication and care to identify spiritual needs and distress, create quality in the system and value that we all want. How? A generalist and specialist model that's team-based and coordinated. Who? Both medical and spiritual care providers can offer such care. They should be certified, licensed, and reimbursed to do so. We should partner with religious communities. For whom? Not just patients, but for providers too, with tremendous attention to this physician burnout issue. When, I would like to propose, not just at the end of life, which is critically important, but throughout life, if Aristotle is right and these issues are critically important to what health is all about. So we need dialogue and funding for this research. So on my final slide, I go back to where I begin, that I am very grateful to the organizers, to the Academy, to all of you. That is the primary religious and spiritual emotion. Reverend Coffin also used to say that spirituality means living the ordinary life extraordinarily well. I love that definition. And he also liked to say, the glory of God is a human being fully alive. And I think that's what this conference is all about. Many thanks again to my colleagues at Harvard, to Dr. Puhalski, to my wife, and to my son for being here, and thanks to all of you.
Thank you, Howard. So, in the audience, maybe one or the other question came up. Please don't forget to fill out the form for the question and hand it to the side so we can discuss it after. Now I want to give the microphone to Dr. Frank Niggemeier. He has a degree in, let's say, comparative religious science that would qualify him for a congress like this, but that's not the actual reason that he's here. In Germany, we struggled very much about the questions of end-of-life care, of euthanasia, of physician-assisted suicide. And Dr. Niggemeier leads the ethical department in the German Ministry for Health. And in this function, he gave us, in the bottom, to the bottom of the discussion, let's say, for the advocacy, very, very good advice how to deal with the politics. And we have some special ways we went in Germany, and now Dr. Niggemeier may tell us his experience. Thank you.
Thank you. Buongiorno and good afternoon, everyone here. First of all, let me thank the organizers for this wonderful conference. It's a joy and honor to be here and to listen to many of you and to learn from all of you. And I will now try to give a little contribution from our experiences in Germany. Which political possibilities, Thomas Sitter addressed it, exist to improve and expand end-of-life care? Of course, such a question must be answered for each country in its own way, taking into account the specific national, maybe even regional circumstances. By circumstances, I mean societal, cultural, religious, and other ways of individual and group-wise thinking, communicating, and interacting. A very important circumstance, of course, is the law, particularly the constitution of a country. In a constitution, people constitute themselves as a nation, as an entity of national and international law. In a constitution, people or their representatives set the framework in which they want to live as individuals, as families, as groups and communities, also as communities of religious beliefs or other systems of world orientation, such as humanism. Taking into account our historical experiences, the mothers and fathers of the German constitution, the Grundgesetz, literally basic law, enshrined as first article, and I quote, "Human dignity shall be inviolable. To respect and protect it shall be the duty of all state authority." So, human dignity is set as the highest value in our constitution. Not the state is the highest value, but the dignity of any human being. This value ranges even before freedom and self-determination, autonomy, because your freedom may be restricted if, for example, you are legally sentenced to a prison punishment, or your self-determination may be diminished, for example, because of a progressive Alzheimer's disease. But your dignity is not. The state has to respect and protect this dignity in any person, also in someone who, for example, because of a certain condition, never had autonomy or has lost self-determination. Of course, there are different views possible how human dignity is to be understood in concrete situations and how it is to be protected the best. I tell you this as a background because in the experiences I want to share with you, this concept of human dignity played a big role. In the discussions which we had in Germany, particularly in the last years, about how to react to the challenge of death in a modern society with its many medical possibilities, people were often referring to the first article of our constitution. The discussion, Thomas Sitter mentioned it, was triggered by dissenting views on certain end-of-life aspects, particularly concerning physician-assisted suicide. This shows that dissenting views are principally not bad at all. They can help to clarify things, to better understand each other, and if possible, reach a common understanding, respectively agree on common solutions. As was mentioned yesterday by Christopher, already in 2007, our parliament agreed to establish a legal claim on specialized outpatient palliative care. But it was also mentioned, this claim could not be realized everywhere, particularly not in rural areas. Recalling a point which was made here as well, maybe the approach of introducing such a specialized claim as a single measure was too narrow. Anyway, things moved on, slowly though. The German writer Günter Grass wrote a book with the title From the Diary of a Snail. In this book you find the sentence, "Progress is a snail." This wise insight applies to many things and situations. It reminds us both to stay continuously engaged and to be patient. So, how did things slowly further develop in Germany? As I said, an important trigger of our discussions and awareness raising was a societal disagreement on physician-assisted suicide. Now, to get this right, it was already mentioned yesterday that we should pay attention not to mix up euthanasia with suicide assistance. In euthanasia, it is the physician who kills the patient on the demand of this patient. In some countries, meanwhile, even on the presumed will of that patient. In German law, also with view to our historical experience, such killing on demand is strictly forbidden and punished. It was not part of the discussion. At the same time, neither suicide nor the attempt to commit it is legally sanctioned in Germany. This leads to the following legal systematic consideration. If an action is legal, or at least legally not sanctioned, also any support to exert this action must be legal, or at least cannot be legally sanctioned. It is for this reason that German law keeps silent about suicide. It also keeps silent about suicide assistance. But this left a loophole for people who, in answer to existing fears and wishes concerning the end of life, started to offer business-like suicide support. So, the discussion we had in 2014-2015 was whether human dignity is better protected if professional suicide assistance becomes part of the office society provides at the end of life, or by which other means human dignity may be better protected. So the task, the political task, and the societal discussion was about creating a balance between dignity and self-determination, the freedom of the individual, and the state's duty of protecting particularly the weakest in a way that corresponds to the hierarchy of values expressed in our Constitution. So we tried to spell out an end-of-life framework marked by dignity and self-determination as a comprehensive approach, a kind of package. This package cannot be realized once and then be preserved for eternity. It is, like often in politics, a never-ending task, which can be described as consisting of several part packages, which in turn contain many more specific single measures. To give you some ideas how things may be developed, I would like to describe 6 pillars of this package by way of example. To start with, the broadest measures we took. In a number of laws, we have created the framework conditions for improving the situation, both of those needing care and their relatives, and of the caregivers. With view to the triggering discussion, the ratio here was the wish to die does not come from nowhere. It has a prehistory. And this prehistory often includes feelings of increasing fragility and the need for help. Elderly socialize less, they lose their sense of hearing, their radius of movement shrinks. This increases an increasing feeling of isolation. Friends and relatives live further away or are no longer around. Here, care services and additional support are very important in strengthening a positive attitude to life. In a modern, mobile, and at the same time aging society, we have to rethink old age. So 20 years after the introduction of long-term care insurance in Germany, we started a comprehensive reform. With this, people can be certain that they and their relatives are not left alone if they need care. They are supported by the benefits provided by long-term care insurance, which covers principally our social insurance system, in difference to the United States, for example, covers 100%. But of course, as I said, things have to develop, even if slowly. So we have increased the benefits in the long-term care insurance by a total of 20%. This corresponds to around 5 billion euros per year. There has not been a single increase of this sort, of this size, in any social insurance system in Germany up to date. So we really took some money into our hands to improve the situation for the elderly. We also started providing help much earlier than previously. In the medium term, up to 500,000 more people in Germany will be able to obtain support from long-term care insurance. We have also created the conditions for increasing the number of support workers from the present level of around 25,000 to up to 45,000 in addition to nursing staff. These additional support workers are intended to help and support people in need of care with their everyday activities, such as going for walks. If you are alone and you don't dare to go out on your own, you need someone who goes with you. Going for walks, playing board games, reading crafts, and so on. This can be of major assistance in improving the quality of life. Another part package of our measure is defined by the principle that the will of the patient is what counts. In Germany, self-determination is legally guaranteed, also with view to the process of dying. Everyone is entitled to decide which kind of medical treatment should be provided and which not, also and particularly concerning the last phase of his or her life. There are different ways for doing this. People should clarify in discussions with relatives or with the doctor in charge what they want. And then there are 3 legal instruments: the living will, the formal authorization of someone to decide for you in situations in which you are not able to decide yourself anymore, and advanced care planning. Legislators and court rulings in Germany have not only recognized this right of self-determination, but also explicitly strengthened it. Thus, the living will, as a formal declaration of intent, with this, it is possible for everyone to bindingly refuse life-extending measures. And any doctor who starts or continues a treatment contrary to the patient's declaration of intent is committing bodily harm and is liable to prosecution. Also, the churches in Germany argue the case for respecting the patient's will and in particular not extending an inexorable dying process artificially. An official statement by the Protestant Church in Germany says, I quote, "The right of a person to ask freely for treatment to be broken off in a futile situation. If further treatment would only extend the inexorable dying process, is undisputed. A person who does not wish to live any longer may renounce nutrition and liquid if palliative support is provided." This also answers the questions which were raised this morning concerning at least my country. A similar position is taken by the Catholic Church in Germany. Unfortunately, not everyone in Germany is aware yet of the ability to effectively declare one's will with regard to medical treatment or to authorize someone to do this if one becomes incapable of making the decision oneself. People, and this was also discussed here, are still reluctant to think and talk about death and to put something down in writing. It's making a decision. So we must continue to provide further information about these possibilities and draw attention to them. It is up to the individual to take the responsibility for making use of this right of self-determination. A combination of good care and support for the elderly can give many people the courage to face life, even as they become weaker and more needy. But sometimes the possibilities are exhausted and the process of dying starts. So for this phase of life, this phase of life is covered by other measures which relate to improving palliative and hospice care. Of course, that was also discussed here, this is not necessarily an either-or, either curative or palliative. You have to look to the situation of the individual patient. Almost everyone is afraid that their death could involve severe pain. Yet palliative medicine has made great progress here. The corresponding theoretical and practical skills must be acquired and further developed. In Germany, we would therefore have made palliative medicine a compulsory, examined subject for all incoming generations of doctors. And the doctors who are already working have a duty to undergo continuous training. Again, progress is a snail that takes time, but you have to do single steps, and I think it was important to make this a compulsory examined subject. We also diminished legal obstacles for adequate palliative care. I do not want to enter the legal details of this, but it may be an important point in your checklist if you consider action on end-of-life care in your country. Look at the legal framework concerning pharmaceuticals. From the progress made in palliative medicine, we can all, especially physicians, learn two different things. On the one hand, we need the will to fight disease and push the boundaries further. We are grateful to scientists and medical doctors in their determination to fight for life. On the other hand, we also need the wisdom to see when life should be left to the end. And thirdly, both will and wisdom must be combined with a clear respect for what the patient wants. As a last resort, if nothing more can be done, there is palliative sedation. We addressed this morning. Also, this ultima ratio is covered by our law. If the patient has previously expressed a wish not to be given artificial nourishment, he or she can sleep through into death. Supporting terminally ill and dying people is a difficult and specific challenge. With the Hospice and Palliative Care Act from 2015, we have strengthened in particular team-based approaches and interaction between professional and voluntary assistance, as well as medical, nursing, hospice and psychosocial support in networks. The aim here is to turn the existing hodgepodge of facilities into a stable network throughout Germany, which will support dying people in the last phase of their life and help and console their relatives in difficult times. But we are not only looking at matters of medical doctors and nurses. It's also a question of how society deals with death and with dying people. The sociologist Norbert Elias examined this aspect already in 1982 in a book entitled The Loneliness of the Dying in Our Days. Norbert Elias describes how death and the dying have been increasingly being pushed aside or completely removed from the life of modern society. And Elias closes his book with the following remarkable words, I quote, "There are many terrors that surround dying. What people can do to enable people to die peacefully still remains to be determined. The friendship of the survivors, the feeling of the dying that they are not embarrassing them is certainly part of this." In Germany, many people have worked hard in recent years to put the friendship of the survivors into practice and to bring people who are dying back into our midst. This shows that politics can do a great deal, but it can do nothing alone. It needs people, it needs the engagement of the civil society. At this point, I would like to pay tribute in particular to the untiring dedication of tens of thousands of people who are active in the hospice and palliative care movement. And also, I see in this hall many people engaging in palliative care all over the world. You all show how each and every person can help to maintain the human face of our societies. Yes. I will skip that because I would like to mention another part package relating to the prevention of suicide, which was also mentioned by Professor Coe. The National Suicide Program, Prevention Program for Germany is central here. So far, more than 90 institutions, organizations, and associations have signed up to this initiative. Several working groups focusing on different aspects are working on the development of framework conditions for effective, regionally adapted structures for improved general measures to prevent suicide, for improved recognition and treatment of people at risk of suicide, and for better care of people after a suicide attempt. It's also important to promote a social climate that prevents suicide and to stimulate research in this field in as many ways as possible. In this area, too, the churches are making a major contribution towards protecting the dignity and lives of desperate people, especially through their telephone crisis lines. The last package I want to mention covers legal sanctions for organized assisted suicide. I mentioned before that there had been voices calling for doctors to be allowed to provide suicide assistance under certain circumstances. But would such a normalization of suicide and its effects on society in general, on the terminally ill, on people needing care and those at risk of suicide in particular, would that be compatible with the system of values in our constitution and the duty of protection through the state? Many citizens and politicians were doubtful about this. But what can be done instead? Undoubtedly, the positive measures that I've just sketched out are important. A general improvement in the care for the elderly, specific improvement in palliative and hospice care, strengthening patients' rights, and continuing to work on suicide prevention. But what about physician-assisted suicide? Some people were in favor of simply leaving this legal situation as it was, so staying silent about suicide and pertinent support. However, this appeared problematic to many people since the loophole in criminal law that I mentioned earlier had led to associations and single doctors offering suicide assistance as a professional service. Many deputies in our parliament wanted to make this business-like facilitation of suicide a criminal offense. In consequence of these considerations, and now that's an important time factor, one day after the parliament had adopted major improvements in palliative and hospice care, one day after this, the following provision was introduced into criminal law, again with a cross-party majority. It reads, anyone who, with the intention of encouraging the suicide of another person, provides, creates, or brokers the opportunity to such person as a business measure shall be punished with imprisonment up to 3 years or by a fine. The rigid proposal to criminalize assisted suicide generally and without any exception found no majority. Neither did the opposite proposal to explicitly allow doctors to provide suicide assistance under certain conditions. With regard to tragic individual cases, the new law in its second para clarified, a participant shall be exempt from punishment if he or she is not acting commercially and is either a relative of the person named in paragraph 1 or is close to such a person. This law does not state whether the participant close to the person in question could be a medical doctor, such as the long-term care general physician of a terminally ill patient. The ratio behind this is, why introduce any special rights for doctors in this area? Neither a special authority to kill or to provide suicide assistance, nor a special criminal law. Udo Di Fabio, a constitutional law expert and former constitutional judge in Germany, showed a wise understanding of the limited capabilities of legal regulation with view to extraordinary situations when he said during the public debate, and that's my last quotation, one cannot, it's a lawyer speaking here, one cannot and one does not need to regulate everything. The important thing is trust in a close relative, in the doctor providing treatment, in the nurse or the priest. There is still an everyday culture which allows standards for the right behavior to grow in an atmosphere of deep affection. So I have described 6 pillars of our comprehensive approach towards life, end-of-life care. You can, of course, add more, e.g. the research we do in this area. But one must keep in mind, policy can only set the legal and financial framework. Such a framework is a necessary but not a sufficient condition. To establish and maintain palliative care as an essential part of a humane society, it also takes public awareness, we spoke about the media, and the engagement of many individuals, groups, institutions on all levels. Even good laws will only work with a civil society engaged to live the guiding values on which the laws are based. Thank you for your attention.
Thank you, Frank. Just in time. So we have good luck. We have only 2 questions here on the table, but very, very crucial ones. And I'm quite surprised to have those 2 questions here, because I thought we discussed it before. But I think the really crucial questions are not outlined enough until now. And actually one question is to the chair and to the last speaker, to Frank Nickemeyer and Eduardo Brera. Finishing hydration and feeding, isn't that euthanasia? Or let's see, assisted suicide. I want to add.
I think, thank you very much for the question. There's no doubt that if somebody is eating and drinking and we suddenly say, no, you cannot have your macaroni and cheese or your water, that would not be nice. So that could be seen as a little bit aggressive. But when we're giving hydration or nutrition by subcutaneous means, nasogastric means, gastrostomy means, etc., it becomes a medical procedure. And it has the same indications as any other medical procedure. So ultimately, it is a balance between, is this making the person feel better, or is this hurting the patient? That will help us make the decision that then that artificial feeding or artificial hydration might be appropriate or not. And so, no, by no means, once you make that decision, that this hydration is only creating problems and not helping very much because the person is already delirious and progressively unresponsive and actively dying, it's just a very wise procedure to do. Same thing is when you are giving nasogastric feedings or G-tube feedings and the person is basically choking or is having no advantage, you decide that that medical intervention is not anymore justified. So I hope that addresses the issue. But my advice is don't take away the macaroni and cheese and the food, the drink of the patient, because that would not be nice.
Thank you, Ed. And Frank, do you have something to add briefly from the governmental or legal German view?
Well, from the German view, I mentioned if the patient previously clarified that he doesn't want nutrition or liquids, we have to respect that. It's only when there is no clarity about the patient's will, then another rule applies, and as we are in Rome, I may say it in Latin, in dubio pro vita. So in doubt, of course, you as doctors and nurses must nourish him and give him or her water. But if the patient decided differently before, after he was informed by a doctor, according to German law, we have to respect that.
And one to all of the table here, all presenters. The African concept of illness, spirituality, palliative care quite differs. Most do both Western and African care for the sick and family. This needs special attention in future meetings. Do you want to add something to different cares? The different views?
Yes. I think that's actually part of a much wider question, and that is how we ensure that we make appropriate generalizations from one setting into another, and how we are sensitive to the important differences. As you can tell just looking at me, I spent most of my childhood in Africa, and apart from being born in Malaysia. So I was very aware at that time that there were very contrasting interfaces. For example, seeing mission hospitals where the different cultures were meeting was often a source of these kinds of questions. But I find it equally, I do a lot of research on the healthcare system around palliative care in the United States. I think it gives us very good insights, largely about what we shouldn't do, but because things are very extreme in those circumstances, you get an insight into processes and mechanisms that you wouldn't get elsewhere. So I think really the onus is on us to be clever at drawing analogy, clever at understanding lessons from other settings, and never going down the road of saying one approach in one country can be generalized more widely.
Then there was a special question to Howard Koh about the funding of spiritual care, really is practical funding.
So actually there are two questions here. The first one has to do with where do I think funding might come for spiritual care? Will it be from insurance companies, state funding, how? Question. So this term of alternative payment models that I've referred to several times is a very cutting-edge topic in American healthcare. And our Centers for Medicare and Medicaid Services, CMS, is the most important agency within the Department of Health and Human Services because they approve the reimbursement of certain payment models. And as I mentioned, traditionally it's been volume-based fee-for-service. In this era with so-called accountable care organizations and hopefully accountable health communities, if there's more emphasis on paying teams of providers to coordinate care, and if outcomes are good and there's savings, everybody shares in those savings. The term shared savings is used a lot. That could be an alternative payment model for the future. And in that second model, the accountable health communities, that's where I think the spiritual care issues could come in. We're seeing some of those cost issues come with evaluation of palliative care, and it's been very encouraging to see that from some of my colleagues because if palliative care is provided correctly, some studies indicate that unnecessary treatments can be avoided, and that could be a source of cost savings. So in short, more attention to these alternative payment models through the Centers for Medicare and Medicaid Services, their innovation center. If we can do those studies and prove those outcomes, improve quality, improve care, lower cost, and there are savings to be shared, that could be a way to go forward. The second question was asking a bit more about connectedness between burnout and spirituality. And I think this issue is just starting to get national attention in our country. Being a physician in our society in the United States is very, very challenging. I'm sure it's very challenging around the world. But in the midst of all the changes in healthcare, all the discussions about the Affordable Care Act, the introduction of electronic medical records, which has provided more stress to the system and to professionals, and the tremendous responsibility for physicians in particular. My wife is here, she's a physician. My daughter is not here, she's a physician. I'm a physician, so I'm very sympathetic to this. And we have some physician leaders in the audience from the United States. Lots of discussion about physician satisfaction, physician quality of life, and meaning and purpose in a physician's career and how to prevent burnout. We know that suicide is another challenge in physician groups too in the United States. We're very, very concerned about those studies. So the article I quoted was one of two in the New England Journal last month. The second one was from Dr. Victor Zhao from the National Academy of Medicine, who is one of the leading health policy experts in the country. So this issue is getting more attention. I'll be fascinated to see if this issue gets global attention, because I feel strongly that the more the doctor, the healthcare professional, discusses these spirituality issues and how it relates to themselves as well as their patients, I think the better off we're all going to be.
Thank you, Howard. So now, Thomas, you didn't have any question, but I want to say I learned something very, very important, to give the best for the poor. That's really important. And I would give you the chance to have the last words here. The last words are very important. But honestly, if you would like, I would like to hear another chant. No, as you want to.
Well, I hope it was as enjoyable to you as it's been to us. There's a huge amount of information available already about the fact that what we do pays the bills and that it can be adapted to different systems. We also heard that the measurements that we need to make are different in different areas, but the opportunity to go back home and argue aggressively for your program to include palliative care, and more importantly, to take advantage of everything you learned today to provide you with the references that will support that what we do pays itself, saves money, improves the reputation of your institution, and overall is an ethical and moral mandate. That gives you enough ammunition to start making the 15 minutes of glory miserable to your dean, the president of the hospital, and the basic so-called leaders that are actually the problem. So thank you very much.
Thank you. Thanks very much. Thank you.
What time do we go on? Photo? Please, for a photo.
So che siete ormai dei professionisti del coffee break, ma non c'è, mi spiace. La sessione riprende subito, soltanto un tempo tecnico per sistemare il palco. Voi potete anche respirare un istante, ma ci riimmergiamo subito nella sessione conclusiva. I proprietari dei poster esposti sono pregati di togliere i poster o adesso o subito dopo la conclusione, perché la sede del convegno sarà chiusa abbastanza velocemente. Grazie.
Scusate, I'm sorry, but we have to start again. It is a pity that we have not coffee, but but this afternoon is busy, and we have also to conclude respecting the time. Scusate, ma dobbiamo riprendere i lavori, è un pomeriggio intenso e vogliamo concludere in orario il nostro impegno. Allora, in questo momento conclusivo di 2 giornate molto intense, molto ricche, spero molto utili anche, perché abbiamo potuto condividere le ultime conoscenze mediche in campo di cure palliative, il contributo delle religioni, gli aspetti organizzativi e l'importanza di promuovere e diffondere le cure palliative. Cerchiamo ora di concludere presentando anche il ruolo e l'impegno che la Pontificia Accademia per la Vita vuole esprimere per lo sviluppo delle cure palliative e per continuare il lavoro che è stato iniziato. Rispetto al programma che avete, il dépliant che avete del programma, c'è un'inversione degli interventi. Cioè il primo intervento di questa sessione conclusiva è del dottor Raja Gopal, che ormai ben conoscete, dall'India, con un intervento sul Social Capital and Community Participation in Palliative Care. Dopo il suo intervento ci sarà la presentazione di un white paper con alcune raccomandazioni in maniera abbastanza sintetica, ed è il foglio che avete trovato nel materiale consegnato per i lavori, e che vuole essere anche poi effettivamente consegnato, queste raccomandazioni, a diversi rappresentanti dei cosiddetti stakeholders, persone coinvolte e che possono essere attivamente partecipi per la realizzazione, diffusione e promozione delle cure palliative. Prego il dottor. Please.
Thank you, chairpersons and dear friends. When I found myself on the program sheet as the last person to speak, I thought there was something wrong. Men rarely have the last word. But Tina has corrected that. Liliana, you win. So thank you for allowing me to go first. Father Thomas and yesterday Father Joby already mentioned the involvement of the community in palliative care in Kerala. I thought I would go a bit deeper into it, explain the relevance, why they are needed, particularly reminding you, I believe that most of the audience here comes from about 10% of the world, the high income or maybe the middle income group. And whereas we, from low income and low middle income countries, form 80% of the global population. For us, I'll explain what's the relevance of the community, the elements of the social capital, how we make use of it. And then I'll just end with a question, is this relevant only to the developing world? The sick should not be abandoned, whether it is in New York or in my village where I was born near Trivandrum. The trials are hard in your country and in my country, possibly a bit harder in my country than in yours. When the Economist Intelligence Quality of Death Index ranked 80 countries, we came among the worst 15. In fact, one of our newspapers carried a headline saying, "Don't die in India, it is not safe." It is bad. In this context, thanking Pope Francis for his wisdom and for what he is doing through us all, I start my presentation about the community. I saw a 37-year-old woman about 3 to 4 weeks back. Well, I saw her because a volunteer identified her and sent her to us. The volunteer said, this girl, the volunteer in the community who knows the local population said, this girl is having bleeding, she has cancer of the uterus, but she has lost all records of treatment. She cannot get treated. I should have asked her to go to the cancer hospital, but then I know what would have happened. What did you do with the records? So I said, bring her over, let us see. When she came, she was in a bad shape, and we put her in our inpatient unit. And when I sat down and talked to her, many things came to light. She did not have cancer. What she had was an incomplete abortion. She was a single mother of 2 teenage daughters, and she couldn't bear the thought of the daughters being ashamed of her. She was really toying with the idea of killing herself. Then what would the 2 teenage daughters do? So she was actually thinking of giving poison to them and then committing suicide. Is pregnancy a life-threatening disease by our World Health Organization's definition? I think sometimes we doctors, and possibly nurses also to some extent, are handicapped by our knowledge. It's like this cup. We already know so much. We know the definition inside out. You can't pour more water in here. Whereas the volunteer from the community is the empty cup. They accept ideas. They lap it up. Actually, it was our professionals who questioned, should we be doing this? How can we take on a case of pregnancy as for palliative care? What would be the alternative? Her suffering is all this. We know that. Isn't it a life-threatening situation? When the woman is thinking of giving poison to her children and committing suicide? Whatever the definition says, we did the needful. She couldn't have possibly completed the evacuation of the uterus in that town because of rumors or scandals happening. We sent her to the neighboring town where a friendly gynecologist quietly did what was necessary. We are also looking after the 2 girls' education now. Why did I mention this? I mention this because I strongly believe that if suffering is not only physical, but also social, mental, and spiritual, it should not be the monopoly of the professionals. For that, 10 million people in my country and maybe 61 million people in developing countries who have, as Lancet Commission said, serious health-related suffering. Where are there going to be enough professionals? What we do have are plenty of volunteers. Now look, here I bring in the concept of the social capital. 2 elements are far apart. The micro element, the woman and her 2 children. We have destroyed the society. We are civilized now. Half a century back, they would have been surrounded by family, extended family who would have taken care of them. But they are urbanized. They are civilized. Nuclearization. And we have those palaces, healthcare system, the macro element, as Dr. Philip Larkin yesterday said. There is a disconnect. There is a disconnect. She cannot get there. Even if she gets there, she is a stranger. And there we bring in the community. Is there any community in the whole world where there are not compassionate people? Where people do not feel good when they are able to help others? But we in the healthcare system have kept them out. We have destroyed the community, and now we have not put anything back in its place. So how we rebuild the community is allowing people from volunteers to help us, to help us in serving the patients. This was World Palliative Care Day. About 40 people on wheelchairs got to the beach. That meant for each 4, there were 4 able-bodied college students, picking them up from the home, bringing them to the road, and driving them across, and again carrying them out of the car. That girl in green and red is paraplegic, like many of them. She doesn't have normal sensation in her feet, but she said, the waves touching my feet was the best experience that I have had in my whole life. What medicine could have given that quality of life? And how could we have given them that quality of life without the support of the volunteers from the community? This is my executive assistant. Her name is Ashla. He's a quadriplegic. She cannot use her fingers, but with the limited ability, she types with her knuckles. She looks after me and tries to keep me in order. Now, that conversion, she came as a patient. We provide her a home. We give her 1 hour of support in the morning and 1 hour of physiotherapy in the afternoon from the system. And she now has been changed from a palliative care recipient to a palliative care provider. She not only acts as my executive assistant, she did a counseling course and is a counselor in our halfway home for paraplegic patients. She is a counselor for children of our bereaved families. And when addressing a large gathering, she said, I believe what changed her life with us was being told that your care is not a charity. That's your right, and we have a duty to provide it. But she added something. If I have a right to care, with whatever ability I have, I also have a responsibility to give to the society and to help others. And that message is essentially the message of community participation in palliative care. We have a responsibility because I could walk to this dais. Tomorrow when I am not able to, if I believe that care is my right, today I have the responsibility to provide it. So how do we do this? The volunteers are there in the community, but they don't know that they are potential volunteers. They are good people. It is not easy. It takes some effort. It is not as difficult as doing a tracheostomy or a craniectomy. It's much simpler. But it takes time, a little time, and that is so well spent. When we know a few people in the community, we start with an awareness program in the locality. Just by saying volunteers come, it doesn't happen. They have to understand what it's about. Most of the time, from that group, there are 2 or 3 people who say, this is important, we must do this. So we get those interested and have a small meeting like that. And whoever volunteers, we make them go through a training program. This is, of course, vitally important. We are allowing lay people to deal with matters of life and death. They could, if they don't know how to wash hands, they could carry infection from one to other, or worse, with one word at the wrong time, they could destroy a life. So we do a 3-day volunteers training program in the classroom. Follow it up with 3 days of hands-on training, whether in the inpatient unit or during home visits. When they have found their feet, we encourage them to form their own non-government organization. What I believe, now that we have had this experience from a quarter of a century, what we learned was that if we just allow them to come and help us, they don't get enough satisfaction. After all, they are being paid only in satisfaction, and that they must get. So we encourage them to take ownership of the program. In that town or that village, they have their own registered non-governmental charitable, or in your, many of your language, non-profit charitable organization. It is their organization. We may be guests. They run it. They take ownership. They take pride in it. They need expertise that we provide. Our doctor will go and our nurse will go once a week. When necessary, a social worker may chip in. And till they have found their own feet adequately, we provide that support. There are some of them who now employ their own doctor and nurse once a week to continue the service. Of course, problems occur. They don't have a degree in palliative medicine or palliative nursing, and they may not have enough expertise. Periodic review of the system is essential. So what do we achieve? In our country, people who develop any disability become bedbound sooner or later. We do not have. In 80% of the globe, there is no effective physical or psychological rehabilitation program. If the community was not there, that volunteer who is in the background, if he was not there, this woman would have had a life-threatening disease because she would have developed pressure sores, she would have been bedbound, she would have developed urinary infections. He and his colleagues go there every day. They went there for more than 3 months and gave her the support, and now she walks. This is what volunteers can do. And with us, they make sure that care reaches people in their homes. The woman in that thatched hut would have never seen a doctor if we had not reached them. And the volunteers make it happen. And they are able then to live there with dignity. And now palliative care involves many things that ordinarily are not done. We now look after the education of 300 children, and it is completely envisioned and executed by volunteers. They raise the funds, they cook meals and sell them on food festivals, as they call it, and raise the money. 300 children getting educated. Most of them would have dropped out of school because they cannot afford an education. And the volunteers themselves thought of the idea of a summer camp for them every year. Most of these children would have very grey lives. No fun, no luxuries, and not even a hug. With a single parent left who is now struggling to keep life going, there is usually no expression of affection. They are also irritable. They are also always angry. And children grow up without love. For 3 days, they enjoy some comfort, some luxuries in life, and they enjoy affection and love. This meso element of the social capital, our communities that can get involved, has to collaborate with the existing healthcare system. And this is not always easy, because I, the doctor, am used to being king in my hospital. The employees are not likely to question me to my face. The volunteer will. If the volunteer feels that he has right on his side, this is unfair, he will challenge me. And if we, the healthcare kings, are not willing to accept that challenge, this will not work. They have to be given independence, they have the right to ask questions, and they will improve the system. This has resulted in my state of Kerala to a public NGO partnership to some extent. The government formed a palliative care policy in 2008. And now, as Father Thomas and Father Thomas said, about 900 small local self-government organizations employ one palliative care nurse who visits every bedbound patient at least once a month. Once a month is not much, but it's 1,000,000 times more than nothing. What has not happened in my state of Kerala even is integration of palliative care into the big hospitals, or integration of the community participation into the big hospitals. Father Thomas's hospital is more an exception rather than the rule. Majority of hospitals do not have palliative care even today and do not accept volunteers. So much so, understandably, the suffering is horrendous, and naturally, we are among the worst 15 countries to die in. Now, I am glorifying community participation. So there are some negatives to it. Now that the volunteers have started doing it in the community, doctors have started saying, well, palliative care is all volunteers' affair. We have nothing to do with it. In fact, some volunteers have started asking, why do we need doctors for palliative care? Now, this is a problem, that balance has been lost. We have the task of bringing the balance back. Social capital, as I read authors in sociology, I understand, carries one thread. Now that palliative care is popular among the community, people are admiring it, vested interests will come in. Vested interests can be personal or even more organizational. Palliative care has a status, it is seen as good, let us go into it. The objective would be wrong. The vested interest can be good or bad. It's okay if they have a vested interest, so long as they do good, that's fine. But suppose they sacrifice the patient for their vested interests, like political parties coming into palliative care, like a religious fanatic organization coming into palliative care. This is always a threat to be guarded against. So, why that community participation, or why palliative care at all? This doctor, just with her stethoscope and with her medicines, couldn't have brought that smile to that woman's face. She gave us that smile about a month before she died. And that, I believe, was the ability of the volunteers. While my colleague, Dr. Amrita, was giving the medicines and doing the physical things, they gave her her love. They made her feel needed and cared for. I'll end with this final question. Is this relevant to only low-income countries? Perhaps it is more relevant to low-income countries because we have those huge gaps in healthcare that need to be filled in. But maybe there are gaps in healthcare in developed countries also. When I visit your country, when I visit a hospice, generally I see very lonely people there. True, they can press a bell and a nurse will come rushing in. But they can't keep the finger on the bell all the time, can they? Aren't there good people in the community? If only we allow them. Can't they give some companionship to these people? Maybe there are things done that can be done elsewhere, but we have systems in place. How about medico-legal issues? How will the system permit it? If we have created a system that will not permit the goodness in the community to live companionship to a lonely person, maybe we need to change the system. It may not be easy, but why does it have to be easy? Most of the easy things have been done in this world already. Only the difficult things remain. Thank you very much.
Ringraziamo il dottor Rajagopal. È capitale sociale sicuramente anche la collaborazione appassionata e spassionata tra due istituzioni come quella tra Pallium India e la Catholic Health Association of India, una collaborazione che dura da decenni, ma che recentemente, grazie anche al progetto Pallife, ha compiuto qualche passo ulteriore, formalizzandosi in una in Memorandum of Understanding, in una dichiarazione di intenti e in una Declaration of Kochi. Very few, yes, very briefly, very few minutes. Thank you.
We are very proud of our collaboration and memorandum of understanding with Catholic Health Association of India, the largest network of healthcare except for the government in the country. We are just waiting to get started as soon as the CHA is ready. And I believe that has the potential within a year or two to remove such a huge chunk of suffering from our country. And I hope that can work elsewhere also. Thank you very much for your interest in that collaboration. And thank you, Father Matthew and Dr. Joby, for the willingness to work in collaboration. Thank you.
Grazie, ora introduciamo gli altri due relatori, sono i redattori, i chair del processo scientifico che ha portato alla produzione del white paper che è stato inserito anche nelle vostre cartelle, e quindi cedo la parola per la prima parte della presentazione del white paper a Carlo Centeno, direttore del Centro di Cure Palliative della Clinica Università di Navarra, Pamplona, Spagna.
Gracias, doctor Sancomoreto. Buenas tardes a todos ustedes. No voy a hablar en español. I will speak in English, but this is only to get your attention because we are at the end of the day. So, at the end of the day, but perhaps a very important moment, because we are going to launch this white paper for global palliative care advocacy from the Academy of Life in the Vatican. And I think that is a very important moment for all of us. What is the Palliative Group? The Palliative Group is an advisor group of the Academy of Life in the Vatican. The mission of this group is to inform and to offer guidance and advice in promoting palliative care all over from the Vatican. And this is very harmonic with the mission of the Academy of Life. The members of this group are people working in palliative care, experts, and very well-known advocators, people that work for advocacy of all around the world. The names are Sami Al-Sarafi from Egypt, Eduardo Bruera, United States, Emmanuel Luirica, Uganda, in representation of all Africa, Daniela Musoy from its countries, Catherine Petus from United States, and also for the International Association for Hospice and Palliative Care, the very well-known Christina Buczarski, that is here too, Rajo Kapal, Thomas Sitte from Germany, Sister Jean Jong from Korea, and also Mari Callaway and Cathy Foley, that I know very well that they are following this session by streaming now. So, people from all regions, from different backgrounds, with different spiritual beliefs, because there are people from many religious or not at all religion. The first meeting, it was in April 2017, here in Rome, in the Academy of Life. In that meeting, we decide what will be the basic strategy for this group, and also we decide 2 actions. The first one, it was to write this white paper for advocacy, and also recommend to the Academy to celebrate this big event, this meeting here in Roma that we are finishing today. The picture is from that meeting. We report the results of this first meeting in one academic journal, in the Journal of Palliative Medicine. It's curious to know that the letter that we sent from the Academy was accepted in almost few days, 2-3 days, and was accepted without any change. This is a good news, because the interest of the world of palliative care about this group is very clear with this action. What is the white paper? The white paper is a position statement of the Academy of Life and represent the most important recommendation that from the Academy we can do for different stakeholders group involved in global palliative care development. About the methods that we use for this recommendation, first we discuss in the group about what will be the best method to use, and after that we decide a list of stakeholders, and we choose one person from each of these stakeholders, and the person writes several recommendations for that stakeholder. Each recommendation is one statement, and the rationale of that statement, and the bibliography. That's the recommendation. And each expert recommends several issues, several things for that stakeholders. After that, we have one consensus process by email, and finally, we ranking the main recommendation. And then we have different versions of this white paper that we are going to present today. Is the brief version, only with the statement, with the 13 statement of this recommendation. But in the next future, that we will have is different version of this white paper, one for one scientific journal, and another with all the recommendations for the public and for the academy. Then 13 groups, 43 recommendations. The group consider all the recommendations of the highest importance. No one recommendation was put out of the list. And finally, the highest recommendation was selected as the main one in the brief version that we are going to present today here. Liliana?
6 minutes. Well done.
Okay, so I will tell you and I will go over the recommendations. Again, my name is Liliana de Lima. I am the Executive Director of the International Association for Hospice and Palliative Care. IHPC is an organization with a global mandate, and we are in formal relations with the WHO and also in consultative status with the Economic and Social Council of the United Nations. So hopefully we can use these recommendations to advocate for better global policy as well as national policy. So now we'll go over the recommendations to stakeholders. This is the first one for policymakers. And what we came up was recognize the social and ethical value of palliative care, and modify the existing healthcare structures, policies, and outcome measures to ensure universal access to palliative care for all patients in need. We will do the delivery afterwards, right? This is the one for the universities and academia. All universities offering degrees in healthcare-related fields should include mandatory palliative care courses as part of the undergraduate curricula. This is the recommendation for pharmacists. Pharmacists should be able to prepare compounded opioid formulations and find ways to make them available and accessible for the patient, especially for children, where it's young, the elderly, and where there are no generic or cheaper formulations available in the country. We're very concerned about the high prices. The recommendation for professional associations and societies to become effective advocates and work with their governments in the process of implementing international policy framework, including conventions, resolutions, and declarations in the countries. Examples include the WHPCA resolution from 2014, universal healthcare coverage, the Sustainable Development Goals, that's the Agenda 2030, and the WHO roadmap on non-communicable diseases. International organizations should encourage WHO member states to develop policies and procedures to implement the WHO resolution as an integral part of their strategies to implement the Agenda 2030 for Sustainable Development, paying specific attention to the needs of children and older persons. Beautiful, huh? I like them. Religious institutions and spiritual groups advocate for the inclusion of spiritual care in palliative care on the local, state, and country levels. Ensure development of professional spiritual care providers or chaplains and their employment stability in healthcare settings. Hospitals and healthcare centers. Every hospital and healthcare center should ensure affordable access to palliative care medicines included in the WHO model list of essential medicines, particularly to opioid analgesics such as morphine. Did you know it's included as an essential medicine? Patients and patients groups. There needs to be a health literacy campaign to increase the understanding of palliative care and the role in the decision-making process for all patients with palliative care needs and their families. So it's about empowering the patients. Healthcare workers. Healthcare professionals working in palliative care should receive appropriate certification while actively participating in continuing education to maintain the adequate competency levels. A lot of these may seem what we have already said, but I think the way that they're enunciated is quite strong. Philanthropic organizations and charities should support palliative care development and implementation. No more palilalia. We need pali funding. So. Recommended areas of funding include increase in palliative care education and training, adequate policies, improving availability and access to opioid analgesics, and then raising public awareness about the palliative care benefits and the needs. Other non-palliative care professional associations and societies is to encourage human rights organizations to take into account existing declarations and implement strategies whose aim is to advancing palliative care development worldwide within the human rights framework. So palliative care is a component of the right to health. Thank you.
Bene, grazie a Carlo Centeno e a Liliana De Lima per aver presentato e descritto questo lavoro, direi laborioso, comunque che manifesta l'impegno che tutti i partecipanti al gruppo hanno posto nel considerare seriamente quello che è stata la proposta da parte dell'Accademia attraverso il progetto Palliative. Ora il Presidente penso voglia consegnare ufficialmente questo primo frutto del progetto Palliative in maniera simbolica ad alcuni rappresentanti degli attori delle cure palliative che sono stati individuati proprio attraverso la produzione del white paper. Presidente, possiamo...
Come avete visto, il Presidente è un po' impegnato, ma volentieri consegno simbolicamente questo testo perché fa parte in qualche modo dell'inizio di una nuova tappa di questo nostro convegno. La consegna è simbolica per sottolineare il coinvolgimento delle diverse realtà legate alle cure palliative che la Pontificia Accademia ha intenzione di sollecitare e di responsabilizzare. Abbiamo voluto fare questo piccolo segno per costringerci amorevolmente, ma con decisione, a continuare il lavoro straordinario di questi 2 giorni. E comincia appunto con la consegna alla prima testimone dopo la lettura del testo.
Benissimo, allora per il gruppo Università Accademia riceve il white paper la dottoressa Adriana Turriziani, professore e direttore medico dell'unità di cure palliative della Fondazione Policlinico Gemelli, Roma, Italia. Per il gruppo farmacisti riceve il white paper la dottoressa Ebdesam Ahmed, clinical professor at St. John's University College of Pharmacy and Health Sciences in New York, US. John Marston. Il prossimo Professional Association and Societies riceve John Marston, Professional Nurse Specialist in Pediatric Palliative Care, Chair of Paul Chase, Palliative Care in Humanitarian Aid Situation and Emergencies. Next group. Pharmaceutical Authorities riceve il white paper il professor James Clary, Professor of Medicine, University of Wisconsin School of Medicine. Per il gruppo Mass Media riceve il white paper Katie Smudge, journalist at the Catholic Missionary Charleston, South Carolina. Per il gruppo International Organizations riceve il white paper Marie-Charlotte Bousseau, Service Delivery and Safety, World Health Organization. Per il gruppo Religious Institutions, Spiritual Groups, riceve il white paper Rabbi Dr. Raphael Goldstein, Executive Director, Neshama Associations of Jewish Chaplains. Per il gruppo Hospitals and Health Care Centers riceve il white paper Dr. Ira Bayok, Founder and Chief Medical Director, Institute for Human Caring, Providence St. Joseph Health Cairns. Per il gruppo Patients and Patient Groups riceve il white paper Silvana Zambrini, responsabile volontari Antea, vicepresidente nazionale Federazione delle Associazioni di Volontariato Oncologico Italy. Per il gruppo Healthcare Workers riceve il white paper Simone Cernese, medico chirurgo, general practitioners and master di secondo livello in alta formazione e qualificazione in cure palliative, Italia. Per il gruppo Philanthropic Organizations and Charities riceve il white paper Reverend Riccardo Mensuali on behalf of Sant'Egidio Community. And for the group, professional associations and societies other than Palliative Care riceve il white paper Dr. Otmar Kloiber, Secretary General, the World Medical Association. Finished.
Prima lascia te.
Before to finish, some words. Credo che si veda chiaramente la mia gioia per questo incontro. Non la nascondo e faccio bene a non nasconderla, perché abbiamo vissuto 2 giorni che non esito a definire straordinari, non solo perché credo sia la prima volta che in tanti ci si ritrova assieme per riflettere in una maniera attenta, profonda, tecnicamente alta sulle cure palliative, ma permettetemi di dire una cosa. Dentro di voi non c'è solo la tecnica, che ovviamente è indispensabile, ma io personalmente ho letto dentro di voi una energia unica. Non solo singolarmente, ma c'è una energia che ci unisce e che ci dà speranza per un cammino che abbiamo il dovere, ma anche il piacere di fare anche assieme. Ed è per questo che sono convinto che abbiamo la possibilità di affrontare un nuovo periodo che chiede a tutti gli operatori delle cure palliative come un nuovo momento creativo. Per me è da poco entrare in relazione con il vostro lavoro. Sebbene oggi io posso dire che tutto quello che voi avete fatto, che io ho ascoltato, ormai fa parte anche di me. La mia esperienza di vicinanza a tanti malati e morenti è una consapevolezza che oggi è molto più profonda per me personalmente. Tra l'altro, uno dei miei primi volumi di storico del Cinquecento riguarda l'accompagnamento che gli allora confortatori si chiamavano, l'accompagnamento dei condannati a morte. Devo pubblicare, lo pubblicherò fra non molto, un loro volume che era segreto. Come accompagnare i condannati a morte, che erano diversissimi. Una finezza psicologica incredibile. Devo dire, cari amici e care amiche, che c'è un patrimonio di accompagnamento a chi muore che è profondo nella tradizione umana. In quella cristiana posso testimoniarlo anche nei miei piccoli lavori di storico. Credo che oggi una nuova frontiera si apre davanti a noi, come già si intuisce dal primo numero del white paper. Oggi si aprono frontiere enormi che riguardano gli anziani e i bambini in maniera particolare. Si è allungata la vita, si allunga anche il momento della morte, si moltiplicano le malattie, si moltiplicano i momenti che richiedono accompagnamento, ed ecco perché io sono convinto che sia urgente da parte nostra di allargare e approfondire la conoscenza e la scienza delle cure palliative. Dall'altra c'è l'urgenza che venga fatta conoscere ovunque. Ed ecco perché credo che questi 2 giorni siano un punto importante. Sappiate che la Pontificia Accademia per la Vita fa dell'attenzione alle cure palliative uno dei suoi punti fondamentali di azione. Via della Conciliazione 1 è la vostra casa. Ed è una casa che, come già qui abbiamo potuto constatare, è aperta a tutti. C'è solo una condizione, quella di non voler mai abbandonare nessuno né alla solitudine, né al dolore, né all'abbandono. E in un mondo iperindividualista, ipercapitalista, dove l'interesse per sé è diventata la prima regola e la cultura dello scarto, una cultura che si allarga sempre più, a noi spetta il compito di promuovere una cultura dell'accompagnamento, una cultura della vicinanza appassionata che renda i momenti più difficili e più delicati della vita di ogni essere umano momenti nei quali senta il calore della scienza e il calore di una fraternità che ci unisce tutti. Ecco perché ritengo che la Pontificia Accademia per la Vita è chiamata a promuovere all'interno della Chiesa Cattolica, partendo da Roma, a promuovere in tutte le sue articolazioni, cominciando dal governo centrale della Santa Sede, a promuovere una nuova sensibilità per le cure palliative nelle università cattoliche, negli ospedali cattolici, negli operatori della pastorale sanitaria. Ci faremo promotori di questa sensibilità, partendo da questi giorni. Ecco perché credo sia indispensabile, ne parlavamo con alcuni di voi ieri sera, che da questo progetto possa nascere l'elaborazione di alcune linee fondamentali che descrivono le cure palliative in tutti gli aspetti che abbiamo anche esaminato, per proporli in maniera autorevole a tutte le realtà cattoliche o cristiane o anche non cristiane che sono interessate alla vicinanza a chi è malato. Questo è un compito che ci richiederà al gruppo di lavoro una responsabilità particolare. Io credo che non dobbiamo lavorare per noi, dobbiamo lavorare per gli altri, per tutti. Ecco perché io penso che davanti ai nostri occhi, e un po' l'abbiamo già visto in questi giorni, c'è il mondo intero, nessun paese escluso, nessun malato messo da parte. Abbiamo davanti i milioni di malati già oggi che attendono amore, compagnia, e avremo probabilmente ancor di più, visto che noi anziani cresceremo, ancor più bisogno di questo. E qui, cari amici anziani, lavoriamo un po' anche per noi, non ci fa male. Questo è un sano egoismo che aiuta anche gli altri. In questo senso penso sia importante coinvolgere tutti i responsabili delle religioni e gli umanisti perché possano assieme affrontare il momento finale della vita, che non è né cattolico né protestante né musulmano né induista, ma è semplicemente umano. E lì siamo tutti uomini e anche donne. Ecco perché alla fine di questi giorni io vorrei dirvi un grande grazie. Un grande grazie perché ognuno di noi ha potuto accogliere, ascoltare e arricchirsi per questi giorni. Personalmente sento una responsabilità molto più grande rispetto a quella che avevo o che sentivo come presidente della Pontificia Accademia per la Vita, e assieme a tutti i membri dell'Accademia riporteremo quanto abbiamo qui ascoltato e anche deciso. Sarà una delle importanti comunicazioni che faremo al prossimo congresso generale della Pontificia Accademia per la Vita, che sarà alla fine di giugno, sulla Global Bioethics, in modo da coinvolgere tutti in questa prospettiva. E permettetemi alla fine di dirvi l'interesse particolare che Papa Francesco ha per questo nostro tema. Quando gli ho presentato il mese scorso il programma di questo nostro congresso, l'ho trovato con un'attenzione particolarmente importante e decisa. È consapevole che questa è l'unica risposta sapiente e umana alle derive eutanasiche, alle derive di una sensibilità di scarto che purtroppo sta allargandosi ovunque nel mondo. Ecco perché mi faccio voce di questa passione di Papa Francesco, che vede nel nostro incontro una risposta bella, audace, umana e proprio per questo anche profondamente cristiana. Cari amici, grazie per il vostro lavoro, grazie per il vostro impegno di oggi, ma soprattutto vi chiedo di accompagnarci con generosità, anche ideale, a questo enorme, vastissimo cammino che ci sta davanti. Scherzando, dicevo a qualche amico, probabilmente ci metteremo più di 6 giorni, ma troveremo il momento per riposarci, quando tanti saranno consolati dalla nostra compagnia. Grazie e buon lavoro a tutti.
E allora con queste parole del Presidente e con questo nostro impegno come Accademia vogliamo esprimere il nostro saluto più cordiale a tutti, ringraziando ancora una volta i relatori e i moderatori per il loro prezioso contributo. Vogliamo ringraziare il gruppo del Palliative per tutto quello che ha svolto e continuerà a svolgere. Vogliamo ringraziare anche tutto lo staff dell'Accademia, che avete capito che è sempre sotto pressione e quindi il lavoro non manca. A voi tutti partecipanti che avete dato con la vostra presenza, le vostre domande e i vostri stimoli un contributo essenziale per il nostro lavoro. Per chi ha svolto anche il lavoro di traduzione, perché non è facile, e quindi grazie anche a voi. Buon ritorno nei vostri paesi, nelle vostre attività e un arrivederci, spero. A presto. Adesso abbiamo mezz'ora di tempo.
Sì, dobbiamo vederci noi, no?
Sì, facciamo
un po'
più veloci.
Sì, no, tanto un po' ci abbiamo già. Ecco.
Grazie.
Bene. Ci vediamo.